growing crisis in metabolic health care due to the shortage of available clinicians to treat this patient community. In 2007, Dr. Korson co-founded the North American Metabolic Academy, an annual one-week intensive course about metabolic disease for genetic and metabolic trainees. To date, more than half of all metabolic genetic trainees of American genetic trainees have enrolled in this course. In 2015, Dr. Korson co-founded the Genetic Metabolic Center for Education, a comprehensive multi-model initiative for improving the level of care for children and adults with metabolic diseases. In October 2017, Dr. Korson joined BNP Genetics in Atlanta as Director of Physician Support to promote telehealth metabolic consulting, assisting physicians in the care of their metabolic patients. Also, as BNP Director of Education, he continues to develop initiatives, resources to help educate specialists and their trainees so they can participate more in the diagnosis and management of metabolic disease. And he's an RNE board member.
Thank you. I'm in the unenviable position of separating you from going home. So this will be fast moving and show some of the things that we're doing to increase awareness about rare disease, but this is really focusing on metabolic disorders. So the title is I Teach, but really is You Can Teach Better. And so I'm hoping that you will take this back to your communities because you are all partners in this process. So, want to know, I'm just wondering whether these are all, yeah. This, see if we can turn this lights down a little. There we go. So, is that okay for you? Okay. So, what keeps me up at night as a metabolic physician? So, welcome to Mark's Metabolic Nightmares. So, if this is the American Board of Medical Genetics and Genomics website showing clinical biochemical genetics and medical biochemical genetics, my specialty, and it shows that since 1982, that there really hasn't been an increase. Despite the increase in number of patients around, no significant increase in the number of physicians that are available. Now, the total number looks impressive, over 400 metabolic clinicians in the country, but the truth is that includes laboratory people, that includes people who certify in this country but went home after their training was complete, but these people are not necessarily available to the patient community. The bad news is that really, in effect, there's about only 140 metabolic clinicians available in this country, available to patients. And that, and data from Barbara Marriage, who is the chief dietitian at Abbott Nutrition, who makes metabolic formulas, she believes that up to 50% of the metabolic clinics in North America are run by physicians who have no formal training in metabolic disease. They're doing it because of circumstance and institutional need. The last year where we have data available about all the patients who are identified by newborn screening is 2006. The CDC stopped publishing, and it's actually very hard to find data out there. But in 2006, there were more than 1,250 metabolic patients that were entered the system that year from newborn screening alone. Now, if you figure going forward that there were at least that many patients from newborn screening each year, and that there are about 140 patients, that means 107 new patients per clinician on average since 2006. And when you're talking about metabolic patients, that's a big burden in terms of workload. But in 2006, in many states, there were fewer than 30 diseases screened for. Now we're over 50 in many states, so the 1,250 patients per year has increased substantially since then. More diseases, more babies. Look at this article from the Boston Globe, Tuesday, October 17th, 2017. And I'll read you a paragraph that during match season for medical genetics this year, just 30 of the 55 spots for medical genetics residencies in the United States were filled. So just over half. So very embarrassing for a geneticist, but we aren't replicating. So what to do. So there's two approaches. One is to attract more metabolic health professionals into the field, and two is to get more specialists to pick up the slack if there's not enough of us. So attracting more health professionals, the problem is medical students, and I'm sort of talking more about medical, but it involves the other disciplines as well, nursing and nutrition. Actually, genetic counseling is doing well. But medical students are savvier now than they used to be. In the old days, people would go after interests like scientific or clinical interests. Now they worry about how much you're going to make. Are you going to have a life out of the hospital, and that kind of thing. And metabolic medicine does not show well. Why? Because there aren't a lot of us, so our call schedule is heavy. The patients are complicated. We don't make a lot of money, and reimbursement isn't particularly well. So, for a person who is looking at the total picture of a career, we don't show very well. And the promise of an interesting genetics career is no longer always sufficient. So we are looking to develop recruitment strategies to attract people into this area, to give them incentives why they would want to be in biochemical genetics. And so we're looking to partner with clinicians, patients and families, and corporate colleagues to come forward. And what you can do as patients is to tell your story. And I'll show you in a little bit why that is important. The other part for attracting more expertise into this area is to educate specialists so they can, again, pick up some of the slack if there are fewer of us. But for the most part, doctors are afraid of biochemistry. They're afraid of biochemical genetics. I introduce a metabolic pathway, and you can see the glaze go over their eye, and you know you've lost the audience. Also, there's a lot of misinformation out there. So uneducated mentors are misinforming their trainees. And it propagates this inaccurate information, which is only complicating, our journey. The other thing is, it's very hard to change the way a physician practices. They just want to get out of the hospital. They want to get up by 7 o'clock. They want to get home and do their notes, and they want to have a personal life. So it's hard to change their practice. So we're adopting a strategy where we're actually going after them. We're going to teach them. But really, we're going to go after the trainees, because the trainees are still formulating how they're going to practice medicine, and they are impressionable. It's also important to remember that who is the intern and resident's boss? It's not the attending physician, it's the senior resident. They spend all day with the senior resident. It's the residents who do most of the education of each other, and so that's where the teaching happens. If they teach each other well and they graduate, they will seed practices around the country. So again, what we need from you is we need you to tell your story. And so let's talk a little bit about that. Why is patient teaching important? Well, let's look at what William Osler said, who is recognized as perhaps one of the premier clinicians in history. He wrote, "To study the phenomena of a disease without books is to sail an uncharted sea. But to study books without patients is not to go to sea at all. Medicine is learned by the bedside and not in the classroom." But look at what's happened over time. In the 1960s, 75% of clinical teaching occurred at the bedside. But once technology exploded, only now, in recent years, 8 to 19% occurs at the bedside because of imaging and lab testing and technology. And the teaching doesn't occur at the bedside, it happens in the conference room. But bedside teaching remains the gold standard for learning how to talk to patients and learning about medical ethics. You have to talk to patients to find that out. In this article from 1980, a thorough history and physical exam can provide the correct diagnosis in 73% of cases on average. This is referring to cardiac issues. For certain problems, over 90%. Take a good history, listen well, and you can make a diagnosis. Why do patients enjoy the teaching role? Well, one, it helps by telling your story. You actually learn more about the illness. You learn more about the condition, and you get a better understanding of the disease through teaching others. Also, it promotes awareness. Simply by teaching, you promote awareness about the disease, and that serves your purpose. So as the expert, you know the symptoms better than anyone. You know the progression of the disease. You know what's worked. You know what doesn't work. And you probably know the research more than 99% of the patients that you encounter. But, okay, so maybe you blend all the facts. You don't know what is relevant, what is entirely medically relevant and not, because you see your whole child. And you may not be able to discern exactly what is the priority, but still, it's all important. Why is patient teaching powerful? Starting in 2006, I started bringing patients into first-year biochemistry at Tufts Medical School. And so what we did is I would provide a brief introductory medical overview of the disease so that the class had a medical understanding of what the patient was about to tell. And then the patients or the parents or both would talk about their diagnostic journey, about living with the disease, how therapy has worked, what are the day-to-day challenges, what doctors do right and what they do wrong. And the difference is I teach facts, but patients tell stories, and that is the big difference. People remember stories. That's why we go to movies. That's why we read books, because we remember. None of you will remember anything I say in a week from now, but I'm going to show you a story, and you're going to remember that family. So what patients provide to physicians is not only information about the disease and information about a patient case, they teach the listener how to be a better health provider by improving communication, caregiving skills, and understanding what the patient is really going through. Scientifically, what does storytelling do? It promotes neural coupling, which means the listener merges the story with his or her own experience to make it more meaningful. You project your own feelings into the story and figure out how it's relevant for you, and it stays with you. Mirroring is where a dramatic story, an effective story, enables the listener to actually live through the events. That's why we cry at movies. We become connected to it. Not only movies, but Hallmark commercials. And it evokes a neurotransmitter release. So if you have a good dramatic emotional story, there's a dopamine release, and that sort of positions that story in your memory to last and influence you for a long time. So who knows here about pyruvate dehydrogenase deficiency? Perfect. So let's watch this. So let's watch this. Okay.
Damon was born and my life changed. All our lives changed. I had a normal pregnancy, what I thought was a normal pregnancy anyway. Very quick delivery. Damien was taken to the nursery, and he had, he was very cute. He was very hairy. He had his tongue was a little tongue-tied. The frenulum was very short. Noticed that very quickly, but he cried. His APGAR scores were fine, and he went off to the nursery. But as time went on in the hospital, they started noticing that his EKG was a little off, and then they determined that it was Wolff-Parkinson-White syndrome, so that was fine. We stayed an extra day. And then while we were at the hospital, we were still going through this process of a very poor eater, didn't want to nurse at all. Being in medicine, I guess he realized that some things maybe don't have answers, but I didn't understand that. And so we continued to go from doctor to doctor to find an answer to why he wouldn't eat, why he had such low muscle tone, why he had such floppiness. And the worst times for Damien were the times that he ate. If you caught him in between feedings, he was happy, he was playing, not normal, because of course, as I said, he was floppy, he didn't have the muscle tone, he wasn't sitting. At 6 months, I said to myself, I don't know what I'll do if he isn't sitting by 6 months.
We were kind of caught up with, well, maybe tomorrow will be different, because that's what we're being told. And, it never really happened. And what it really came to a head was about a year of age. We were in
Right.
Buffalo doing training, and with no answers. And her father actually made an appointment with a doctor in town in Boston and saw Damien and decided to do some blood tests.
The results from the Buffalo Children's Hospital came back that his alanine was,
Very high, very high.
I honestly forget how much higher than normal it was, but that gave them a clue as to what possibly could be the problem. So for a week, we stayed there and did all kinds of tests, and they came back with the diagnosis at the end of the week of pyruvate dehydrogenase deficiency. On the way back to Buffalo, it's like a 9-hour drive. We're talking and how we're going to start our lives with a child like this, and we decided that we were going to try to live the most normal life. And if we said we were going to do something, we were going to do it, and that was our plan. So we arrived in Buffalo on Sunday evening, and Friday night we decided to go for pizza because we also had a 3-year-old, and Damien decided to be very, very lethargic that night, and we said, no, we're not going. And then we looked at each other and we said, nope, we're going. We put him in the car to go for pizza, and 10 minutes into the ride, I turned around and he was unresponsive, doing a breathing that I had never seen before. He was sort of sucking in air, but his whole face was sort of pulling off to the side. And it was just, this was the first time that we had ever seen anything like this. And he was in an acidotic episode. We didn't know that. We got him to the pediatrician. The pediatrician rushed us to Children's Hospital. Children's Hospital told us that he probably wouldn't make it through the night. Family members came up, and one doctor there who had a little knowledge of pyruvate dehydrogenase deficiency decided to give him thiamine. And when we saw him in the morning, he was a different Damien. He was alert, holding his head up. I know it sounds crazy, but that's what it was. And he said, how does he look to you? And I said, he looks better than I've ever seen him. And that was probably the start of Damien's life. And what they told us, that what we were feeding him was all wrong, but that my struggle got enough of the good stuff that he needed into him. And that's how he survived. So once he got on his new diet, then he became the Damien that I know now.
Yeah. So that basically at that point, we could move forward because we had a diagnosis and we had a way to deal with it. Now, unfortunately, they didn't know as much as they know today, but I guess the point of all this is to get that knowledge out there.
All right. So, for those of you don't know pyruvate dehydrogenase deficiency, which of the following are 2 major presenting symptoms of PDH deficiency? Hypertension, low muscle tone, osteoporosis, feeding problems, or heart failure? 2 and 4. Who taught you? All right. So let me tell you about this family. So they have been very significant patient teachers. And while Damien was alive and after he passed, they continued to be teachers. So I was, they taught at Tufts. Now at Tufts, 2nd and 3rd year medical students, if they don't rotate through pediatrics in Boston, they either go to Eastern Maine Medical Center in Maine, in Bangor, or Bay State Medical Center in Springfield. So I was up in Bangor teaching, and they said, the medical students here from Tufts rotate every month. While you're up here, can you sort of give them a lecture? And I said, absolutely, I'm here. So I walk into the class. These are 3rd year pediatric medical students. And one of them comes up to me and says, "Are you the guy that brought in bottom patients in first year biochemistry?" I said, "Yes." "How is that patient with pyruvate dehydrogenase deficiency doing?" Now, find any third year medical student who spontaneously mentions pyruvate dehydrogenase, I'll pay you $100, because it doesn't happen. So I recovered from my faint, and I got up and said, "Well, do you remember what the symptoms were?" And they said, "Yeah, he was floppy and he didn't feed well." This is spontaneous memory. And do you remember what the test was? Now, the parents talk about alanine, but in biochemistry, you learn that alanine and lactic acid are directly related. So he said lactic acid. 2 years later, unprovoked, he came up with a kernel of information that was important to recognize, to think of the diagnosis and know what test to order. That is powerful teaching. And I didn't do it. Those parents, Damien's parents did. So what are we thinking about? And this is where you come in. So our hypotheses are that a health professional is more likely to recognize a diagnosis if he or she has seen an affected patient before and has heard his or her story. So that's why at RNE, we initiated last year the Rare Disease Day Speaker Series. Now, Rare Disease Day is February 28th. And so last year, around February 28th, in honor of Rare Disease Day, we went to 6 medical audience sites to bring patients to talk about their story. And it reflected the patients. This was actually a rather last-minute project. So there's a focus on porphyria and Barr syndrome, but that's okay. And so this year we're expanding that, and this is on our list for this year. We may actually get one more program. Any of you who are interested actually in participating in organizing the Rare Disease Day or participating in any of these programs, let us know, because we could certainly use the help. So that's Rare Disease Day, but we're going further. We're ramping up medical school because it's too late. I mean, it's not too late. Yes, we can go after neurology residents and GI residents and pediatric residents. That's fine. But we're going to go early. We want to get them as early as possible. We're going to medical schools. And we're going to first year because biochemistry is taught in first year, and metabolic medicine is the direct clinical application of biochemistry. You show me a biochemical pathway, and I'll introduce you to someone who is coping and living with a defect in that chemical pathway. It puts the human back in human biochemistry. So there is something called the Association of Biochemistry Educators. So very dear to my heart, these are the biochemistry course directors who are representing 140 medical schools and osteopathy schools around the country. And guess who is giving the keynote address next year? So what is their goal? They want to make biochemistry relevant. They're being pushed out by the clinical departments who are saying biochemistry isn't relevant, cardiology is important, surgery is important, obstetrics is important, but we can show them why biochemistry is relevant. And so, what I want to be able to provide them next May is why should patient teaching only be occurring at Tufts, and I also do it at Boston University, and there are some centers around the country, but why not make patients available to all these medical schools to come in and talk at lunch hours and show how biochemistry is relevant. So we are starting to go to disease foundations asking for volunteers who want to tell their stories. We are also looking for patient videos. Videos like that, like we produce that, but there are patients and families who actually, or disease foundations that have done that, that have patients telling their stories. All we need is a 5 or 10 minute clip that a biochemistry lecturer is talking about the urea cycle, who can download a 5-minute clip and enhance that lecture and make that lecture come alive. So we're looking for information about these videos that exist. And right now, so far, we have a small collection representing a series of metabolic diseases. Our other hypothesis is a medical student or trainee is more likely to become interested in this field if he is or she has seen an affected patient before. And here's our data for this. Before I started bringing patients into the classroom, I saw zero, when I was at Tufts directing the metabolic clinic, I saw 0 first-year medical students. After we started introducing patients, 18 came in to do electives. Of that, 3 came back to do summer projects, a 4th enrolled in the American College of Medical Genetics Summer Scholars Program, and 3 declared that they wanted to pursue genetics training. Did I have anything to do with it? Was that going to happen spontaneously? Sure, we don't have a control group, but I like to think that I have some, I have some role in that. The other thing that we're doing is doing medical electives. So what is a medical elective? A medical elective is if a neurology resident comes to me and says, gee, you know what? Could I shadow you for the next 3 months every Tuesday afternoon when you're in clinic? And sure, and when they come to clinic, they see me see a patient, they see me interview a patient, they see me do an exam, they see the counseling, and then the patient leaves and we go out in the hall and we talk a little bit about the case, a little bit about the disease, and we go and see the next patient. And they are seeing patients that he or she might not otherwise see in their clinical rotations. Why can't we do that online? So what we did recently, in conjunction with the North American Society of Pediatric Gastroenterology, is we had 2 pilots where we had 15 pediatric GI trainees around the country who logged in at this time, and together we saw a 10-minute clip of a patient talking about OTC deficiency, and there was a short PowerPoint presentation and a Q&A, and then we saw a clip about a patient talking about living with porphyria, and there was a PowerPoint presentation, a Q&A, and that was it. And they saw patients they might not otherwise see before. Now, there's not enough of us in metabolism, but these specialties and more see these patients before they ever come to us, because these patients present with symptoms that are in those specialties. And so we're looking especially right now at neurology, GI, nephrology, and we're looking at 105 residents who take call, who are enrolled in these programs, and we are going to plan online metabolism electives to the neurologist. So these are metabolic disease with neurologic manifestations, so they are relevant to these patients. And we have a program planned with the American Society of Pediatric Nephrology to do the same thing. And if this is successful, then we become part, sort of a component of pediatric GI or pediatric neurology training going forward. That is part of their training, they have to participate in these electives. So again, we are introducing patients and disorders that these trainees may be seeing, but they don't know what they're seeing. And you can't rely on their mentors to teach them because their mentors were never trained in this area either. So I can do some of the teaching, but I need help from you to do the teaching as well. And so we are looking to collaborate with patients and families and disease foundations, advocacy foundations, organizations, and pharma companies who are interested in these diseases. Some of them have actually done some of these videos, and so they're available. But what you can do is be an active storyteller, help us brainstorm, and help support the effort. Help us help you. Thank you so much. I'll take a couple of questions, comments. It's late. Yes.
Any comments on the differential impact of videotape versus live storytelling?
A good question. It's what do you prefer, theater or television? Mm-hmm. It's sort of the same thing. Television is much more, you can bring the story to so many people, but there's something that you can't. But live theater you can't replicate online, so on a screen. So they're both powerful in their own way. They have their pros and cons.
How about studying pediatrics?
Pediatrics is good. It's just I'm actually Dr. Leah Burke in Vermont and I are actually participating in a general pediatrics outreach project right now, and through Connecticut, and their priorities are much more general, like the common things, diabetes and asthma, infections and strep throat, and this doesn't figure very prominently. So, and if any of these patients get really sick if they don't have a diagnosis, they refer them to the ER, they refer them to a specialist. So yes, we could focus on very specific topics for them, but that's probably not our target audience. All right, it's late, go home. Thank you.